Hey, what's up guys? Today we're going to be talking about medications that specifically lower mortality in congestive heart failure, but specifically we're going to be touching on two new medications that aren't really talked about all that much in the guidelines because they've been recently approved and they've been proven to reduce mortality. And after all, we give medications to patients with heart failure because we want to improve patient outcomes. We want to decrease time spent in the hospital. But aside from that, we want to make sure that these patients live longer. Morbidity means decreased time in the hospital. Mortality means it improves their lifespan. So let's very quickly recap what medications have been given in the past with proven mortality. Now, very quickly, diastolic dysfunction, right? So we can separate heart failure into diastolic dysfunction and systolic dysfunction. Systolic dysfunction means that ejection fraction is reduced. The amount of blood that pumps out of the heart isn't normal. Diastolic means we have a preserved ejection fraction. So in diastolic dysfunction, we actually don't have any medications that improve mortality outcomes, or decrease mortality, I should say. So all of the medications in diastolic dysfunction are geared more towards symptomatic control and or comorbid conditions such as hypertension, hyperlipidemia, atrial fibrillation, things of that nature. Systolic dysfunction is a little bit different. We do have medications that reduce mortality. The main classes of drugs here are going to be beta blockers and ACE inhibitors and or the ARB. Now, beta blockers does not have a class effect, meaning there are only three medications in the beta blocker class that reduce mortality. This is bisoprolol, carvedilol, and metoprolol succinate. These three medications are important to note. Atenolol does not reduce mortality. You have to do bisoprolol, metoprolol, carvedilol. ACE inhibitors, or ARBs, on the other hand, is a class effect. This means that it doesn't matter which one you choose, whether it's enalapril, lisinopril, they're going to reduce mortality. And you never want to combine an ACE or an ARB. Now, we also have the spironolactone and eplerenone. These are medications that are going to be given in class 3 or class 4 congestive heart failure. You're not going to use both of them. Spironolactone and eplerenone are used as one and the same. The difference is eplerenone has less endocrine side effects. Other medications that are commonly used in the treatment of heart failure are going to be diuretics and digoxin. Now, diuretics do not reduce mortality. They are simply there to relieve symptoms of fluid overload. Digoxin, again, although it does decrease the amount of time in the hospital, it does not decrease mortality. It is going to improve symptoms such as shortness of breath. It's going to affect contractility of the heart. So digoxin does not improve mortality. So really the main medications here are going to be beta blockers, ACE inhibitors, eplerenone, and or spironolactone. Now, the two new medications that we're going to be talking about today are going to be Ivabradine and Sacubitril. Now, Sacubitril is going to be a combination drug with Valsartan, and we'll get into the specifics in just a second. So let's start off with Ivabradine. All right, moving on to, or starting with Ivabradine. Now, what Ivabradine does, it's going to affect the SA node. So it's really targeting the SA node. It's prolonging the depolarization phase. And ultimately what we're doing is we're slowing down the heart, increasing the amount of time the heart has to fill with blood, and essentially providing a similar benefit to that as a beta blocker. Now, you have to be aware this is not a substitute for a beta blocker. So in order to be a candidate for Ivabradine, we have to have an ejection fraction less than 35%. We have to be on the maximum tolerated dose of the beta blocker. Like I said, this is not a substitute. And or maybe there's a contraindication to a beta blocker, which is why we're going to be then using Ivabradine. We also have to be in normal sinus rhythm, and we have to have a heart rate of at least 70 beats per minute, because this is going to affect the SA node. It's going to decrease the amount of times that the heart pumps. So if we already have a rate of 70 beats per minute or 60 beats per minute, we don't want that falling even lower. So a minimum of 70 beats per minute. An aside, the heart rate cannot be controlled by a pacemaker. So we have to have sinus rhythm, ejection fraction less than 35%, maximum tolerated dose on a beta blocker in normal sinus rhythm with a heartbeat of at least 70 beats per minute. These patients are candidates for Ivabradine. Moving on to contraindications for Ivabradine. Now, we have to keep in mind this is going to be only used in stable congestive heart failure. This means one of the contraindications here is acute exacerbation of CHF. We do not start this medication when we have acute exacerbation. Another contraindication is going to be hypotension, which is defined as a systolic of 90 and a diastolic of 50. SA dysfunction, SA node dysfunction, severe hepatic impairment, and or if the patient is taking a strong CYP3A4 inhibitor. Now, all of this data is really coming from the SHIFT trial. The SHIFT trial had 6,558 patients. They were then divided, half were given placebo and half were given Ivabradine. They were then followed for a period of about 2 years. After the 2 years, they noticed that the patients that were taking Ivabradine had decreased hospital admissions, and overall there were a decreased number of deaths. And this is where the evidence comes for Ivabradine. Now again, remember, in order to be a candidate for Ivabradine before starting therapy, patients have to be on the maximum tolerated dose of a beta blocker. They should also be on the maximum tolerated dose per guidelines of an ACE inhibitor. Now, if the patient has a contraindication to a beta blocker, they should be started on an ACE inhibitor first and then started on Ivabradine. Moving on to the dosing of Ivabradine. Now, we're really going to start the medication at 5 milligrams twice a day with food. Those patients that are at high risk for having conduction disturbances should have this dose cut in half, meaning we do 2.5 milligrams twice daily. Now, every 2 to 4 weeks, we're going to titrate upwards until we get a maximum dose of 7.5 milligrams twice a day. We want to either stop medication or reduce the amount of medication given if we get a heartbeat of 50 beats per minute or less, or if we're having signs and symptoms of bradycardia. If we're at 2.5 milligrams twice a day, it's the initial starting dose, we're already having a heartbeat of less than 50, or we're having signs and symptoms of bradycardia, then we're going to stop the medication altogether. Adverse reactions. Now, like we said, this is going to affect the SA node. So one of the adverse reactions here is going to be bradycardia. Now, unlike a beta blocker, this is going to have an increased risk for causing hypertension, not hypotension. We also have to be on the lookout for heart block and atrial fibrillation. Moving on to Sacubitril. Now, like we said, Sacubitril is going to be combined with Valsartan, which is an ARB. Some quick background information before getting into the specifics. ACE inhibitors and ARBs are going to be responsible for affecting the renin-angiotensin-aldosterone system. Natriuretic peptides are going to be released when we have increased myocardial filling pressures. What these natriuretic peptides do is they're going to reduce the amount of renin released by the kidneys, they're going to increase the GFR, they're going to cause vasodilation. In essence, natriuretic peptides are good. All right, so let's talk about neprilysin. Now, this medication, Sacubitril, is a neprilysin inhibitor. Neprilysin is going to decrease the amount of natriuretic peptides, it's going to break down angiotensin II, and it's also going to decrease bradykinin levels. So when we give Sacubitril, this neprilysin inhibitor, it's going to produce the opposite effect. It's going to raise bradykinin levels and it's going to raise natriuretic peptides. Because we have this increased bradykinin levels, because it's breaking down angiotensin II, this is why we need to combine it with a medication that affects the RAS system, the renin-angiotensin-aldosterone system. This is why this medication is combined. Now, initially, the neprilysin inhibitor was combined with an ACE inhibitor. They took this off the market. The FDA actually pulled this off the market because although it did improve outcomes, there was a reduction in mortality. They noticed there was severe angioedema because this ACE inhibitor that was combined with the neprilysin inhibitor actually affected 3 enzymes that were responsible for this effect. Now, when we combine it with Sacubitril and Valsartan, Valsartan being an ARB, it's only affecting 1 enzyme. So, in essence, this new combination drug of Sacubitril, which is the neprilysin inhibitor, and Valsartan, which is the ARB, is going to only affect 1 enzyme out of the 3 that the original medication affected, 1 enzyme responsible for bradykinin degradation. So overall, this medication is going to block the renin-angiotensin-aldosterone system. It's going to reduce the amount of risk for angioedema, and it's going to raise natriuretic peptides. Now, this combination drug, like we said, is an ARB and it's a nephrolysin inhibitor. This means that we should not combine this medication with any other ARB, and we should not combine this medication with any other ACE inhibitor. Now, what's not so clear is when to use the medication first line. Now, we do know who it's indicated for. This is indicated for the CHF patient that has class 2, class 3, or class 4 CHF. We're not so sure if we should use this combination drug in place of the ACE inhibitor first-line therapy, or if we should use this combination drug instead of the ARB monotherapy if for whatever reason we cannot use an ACE inhibitor universally. There are some exceptions where this might be indicated first line. So if the patient can't tolerate the ACE inhibitor for whatever reason, we do know that this combination drug is better than ARB monotherapy. When we have increased BNP levels, we have a systolic blood pressure over 100, and we have a GFR over 30. This combination drug is better than ARB monotherapy. Now, to dose this medication, we're really going to be starting at a dose of 49/51 twice a day. We're going to then titrate again in about 2 to 4 weeks to reach the maximum dose. And if we have severe renal impairment, then we're going to start the titration, or we're going to start the initial dose at half the recommended dose, so half of 49 milligrams over 51 milligrams for the combination drug. Now, all of this evidence and all of these guidelines are really coming from the Paradigm HF trial. This trial had 8,442 patients who had an ejection fraction less than 40% and who had CHF class 2, 3, or 4. These patients were then split. Half received enalapril 10 milligrams twice a day. The other half received the combination drug. They were then followed for about 2 years, and after the 2 years, we realized that the patients receiving the combination medication actually had decreased all-cause mortality and had fewer hospital admissions. So this is where all of the evidence comes from, the Paradigm HF trial. Now, contraindications to the combination drug of Valsartan and Sacubitril are going to be the same as any other ACE and ARB contraindication. We're going to want to avoid this in pregnancy because it can have teratogenic effects. We're also going to want to avoid this in patients who've had prior severe angioedema because although the risk is low, it's still a life-threatening event. We're also going to want to avoid this in patients who are breastfeeding, and we're going to want to avoid this in patients with severe hepatic impairment. Adverse reactions for this combination drug of Sacubitril and Valsartan are going to be hyperkalemia, hypotension, cough, dizziness, and even renal failure. Angioedema is also a risk here. It's going to be low, but again, this is going to be a life-threatening event, so we still have to be aware of its presence. So that concludes today's talk. We talked about Ivabradine, we talked about Sacubitril, which is essentially a combination drug with Valsartan. These both reduce mortality. Like we said, these drugs are only reducing mortality in patients with systolic CHF, with systolic dysfunction. We do not have any proven therapies that reduce the mortality in diastolic dysfunction heart failure.